University Grand Rounds, and we'll start promptly. Professor Siok Choa is going to give us a talk on the SAVVE trial, insights into the veno valve, and then we'll be followed by two professors, Professor Goel, as well as Professor Joa. So the floor is yours.
Thank you. Thank you, Dr. Kabnik, for the introduction. My talk will be talking about the veno valve and the SAVVE trial and share what insights we have from that ongoing trial. These are my disclosures. Deep venous reflux treatment has been really by compression therapy, various forms of compression therapy to various grades and degrees. And in addition to that, for patients with venous leg ulcers, who a significant proportion of patients have deep venous reflux, we do wound care, various forms of wound care. But really for those patients with leg ulcers, after we treat the superficial venous reflux and potentially venous outflow obstruction, we have not had any surgical option to treat deep venous reflux or correct it. There has been a lot of publications on deep venous valvular reconstructive surgery, and that has been very nicely summarized in a recent systematic review by Dr. Maletti and al. From Italy. However, there's been a lot of different techniques and a lot of different strategies and the dissemination of that surgery has been very limited to only a few centers worldwide. One novel treatment is to have the bioprosthetic valve that does the job of the deep valves and replace them. And the veno valve is a valve that's been designed for that. It has a metal frame and in porcine aortic valve that's sutured to it. And this has been tried in a smaller group of patients, and that study was led by Dr. Ulowa and published with very good results. So the SAVVE trial is the United States multi-center trial looking at the veno valve. And in that trial, patients who had deep venous reflux of at least a second and advanced venous disease, C4B, 5, or 6, were enrolled in that trial. All those patients, the majority of patients had C6 disease, and all those patients were ruled out for lymphedema. If they had superficial venous reflux or iliac vein obstruction, had those treated and taken care of prior to enrolling in the study, and they had persistent symptoms and deep venous reflux. When we look at patients with ulcers in that study, 75% of those patients who had ulcers, which are the majority, approximately 60% of the patients in the trial, had an ulcer for more than a year. So those are the patients that come to your clinic who have ulceration. You try different forms of compression. You try to rule out any other concomitant pathologies, and they just come back. And really, there's no option for them to treat the deep venous reflux. So we enrolled 75 patients in that study, and this is the most recent data that we have for 2 years follow-up. And you can see that the VCSS score, the Venous Clinical Severity Score, significantly decreased in all the patients in the group from 16 to 8.9 after 2 years. And if you look at the clinically meaningful improvement, which is defined in the study as a VCSS decrease of at least 3 points, you see that this group of patients even had more improvement than the overall population, and there's a significant proportion of patients who had clinically meaningful improvement. Looking at the percentage of patients in that trial who had clinically meaningful improvement or a VCSS score decrease of 3 points or more, you can see that 84 or more than 80% basically of the patients at 1 year and 2 year had that outcome, that improvement in outcome, which is really remarkable for this challenging patient population. Pain score dropped by at least 50% also. That is sustained, and the pain drop started early on at 3 months, but was sustained up to 2 years, as you see in this graph. And parallel to that, the patient's quality of life, as was measured by the VANS SIM and the VANS QOL tools, significantly improved. And this is the VANS SIM tool, and this is the VANS QOL tool, and both had improvement around the same time that the pain score improved, around 3 months, and that improvement was sustained up to 2 years so far. Now, when we look at the venous ulcers in that trial, venous ulceration was looked at as presence or absence and complete healing, but there was also assessment of the surface area of those ulcers. And there's an application, the SWIFT app, that measures based on images and a calibration tool, the size of the ulcers, and the surface area reduction was also measured and traced. So if you look at ulcer healing in general, you can see that approximately, and this is only looking at 1 year because the analysis for the surface of ulcers have not been done for the 2 years, but it's in the works. You can see that 50% of the ulcers completely healed and 91% improved or healed at 1 year after placement of the veno valve. And if you look at the surface area of ulceration, that significantly decreased from 17.4 centimeters square at the beginning. There was to 2.1 centimeters square total at 1 year. And this is a similar curve, but showing the percent reduction of ulcer area. You can see that there's an early drop even within a month after the surgery, and that continues all the way to 1 year, from like an 88% reduction basically in the surface area of the ulcers. Now, this analysis was stratified by the time of ulceration, the duration of ulceration, and you can see that the patients who had ulcers of duration of 1 month or less than 3 months, those almost completely healed, with very good in a very fast period of time. But you could see that on the other hand, patients who had ulcers for more than 1 year, their trajectory was a little bit more retracted, and it took a longer time to heal those ulcers. But still, overall at the 1 year mark compared to the time of surgery, you had an 85% reduction in the surface area of ulceration, which is a great improvement for this patient population. The improvement in VCSS score, this is looking at only patients with ulcer, is very similar to the overall patients. And the improvement in the VCSS also at 1 year was similar to the overall population. Another analysis that we looked at and into the SAVVE trial, we looked at patients who had history of DVT versus patients who did not have history of DVT prior to treatment. So the thrombotic patients, which constituted 80% of the patient population, 20% of the patients did not have any history of prior DVTs. And we can discuss that with Dr. Ulloa. We have already had some discussions that, maybe all of them have thrombotic events, but maybe we don't know, or clinically they were not brought to the attention of the physician at the time. Regardless, the characteristics of the patients were very similar baseline, as well as the characteristics of their reflux pattern and VCSS score were very comparable. I don't have that slide here for the sake of time. And if you look at those two patient populations, you can see that the improvement in VCSS was significant in both. In green, you can see the patients who had primary reflux, and the patients who have not thrombotic reflux is in orange, and both had a significant decrease at 1 year in their VCSS score, 8.7 drop in the primary versus 6.2 in the patients who had post-thrombotic syndrome. And similarly, the patients who had the clinically meaningful improvement, which is 85% of the group in that analysis, both had also significant drops in their VCSS scores, 7.5 and even 9.3 in the patients who had primary insufficiency. So in conclusion, the veno valve is an effective treatment for patients with deep venous reflux and ulcers, and despite conventional medical and surgical therapies. Ulcers, especially the ulcers of more than 1 year duration, this group of patients healed more slowly, but they did have more than 80% reduction in the area of ulceration after 1 year, and they benefited from the surgery. And the overall improvement in measures and quality of life for advanced venous reflux and deep venous reflux really opens the an opportunity for those patients and who have really no other options to have some surgery that can improve their patients' outcome and also an option that lasts, that's durable at least for 2 years so far, as long as the trial has been collected. And we're starting to collect data for the 3-year outcome. The device is getting reviewed by the FDA and hopefully will get approved in the near future. Thank you very much and happy to take any questions.
Thank you very much, Siak Chara. That was unbelievably exciting. Obviously, there are going to be lots of questions. We do have one already, and that's patency of the valve in your trial. And that was suggested by Dr. Rashad Bashara from Egypt.
Yeah, so the incidence of thrombosis and DVTs was approximately 10 to 12% in the trial. Few patients got thrombectomy, mechanical thrombectomy, and the patency of the vein and the valves was reestablished. And some even patients who had DVTs in the area and did not get a thrombosis, a lot of the DVTs resolved with time. And based on, I would say, equivocal ultrasound results, because of the metal frame, you cannot really see inside the valve. You cannot assess whether the valve has reflux or not. And that has been one of the major challenges of that trial. But based on the patency of the vein below and the respiratory phasicity, so basically showing that there's respiratory variation in the vein where the valve is implanted, it's 90%, 98% actually.